Hi everyone, how are you all? Welcome back to my channel. I know I didn't film in a while now because I was towards the end of my placement and yesterday was my last day, and to be honest it was really busy and I was super tired, so I couldn't feel much, and I was back again on AM shifts, which means I was coming back home at about 4:30, 5 o'clock, at PM time. And yeah, the sun was down already. We are now at winter time in Australia, so I couldn't really film much. So yeah, so today I thought I will film sort of like a recap video for you guys, telling you how my whole placement went. And if you're a person who is interested in working maybe in Interim Care Unit ever in your life, or maybe you will be a student who will be sent to this unit for prac, okay, maybe this video will be sort of like an indication for you to what to expect, and also sort of like I will tell you what I've been through and sharing just my own experience. So anyways, now it's been 3 weeks of my placement. That's all in total 120 hours. So I had opportunity to see how this unit runs in the morning and on PM shifts as well, because my first week I was on AM and then I went to PM for 1 week and went again on AM for the last week. So I had that experience to see, what the nurses do, throughout these 2 shifts, how the cares differ, and the whole routine and stuff. So I can tell you that generally PM shifts are more quieter and more cruisy than the morning shifts. Morning shifts are more busier and sort of like giving you a feeling that it's passing quicker, whereas when you're on a PM shift sometimes it feels like it's going for ages, and you finishing like almost at 11 o'clock and starting 2:30 or 3 o'clock. So it's pretty long day, especially if it goes really slow, the way it feels. So this is just my own like experience. That middle week when I had my PM shifts, they were so relaxed, so cruisy, so quiet. We had our medication administrations. You will have the same sort of like cares as you would have in the morning, apart from showers. Like you will have all your hygiene cares are done in the morning, and then in the evening you may help your patients to sort of like change into nighties or pajamas, and go back to bed. For those who've been out of the bed, you still would do your 8 o'clock medication rounds. Some you will have at 9 o'clock, some at 8 o'clock, but your major ones, sorry, at 10 o'clock, but your major ones would be at 8 o'clock, and then some most of the time at 10. And yeah, you will do a few BGLs at that time as well, and you will still assist with feeding for dinners and stuff. And yeah, it's not much of things to do. And then you will do your progress notes, and then you will do the handover to the night stuff. Okay, so in the morning, on the other hand, it's more busier because the whole routine with showers and hygiene cares and stuff like this for your patients is just going really like busy. You will have so many people to be washed, showered, changed, and then you have to assist them in feeding for those who can't eat by themselves and stuff like that, and then you have your medication round coming at 8 o'clock, which is pretty much the same time when the breakfast comes as well, so it's full on in the morning. So looking at it back now, I can say that morning shift passes really quickly, even though you start really early. Like we start at 7 o'clock and finish 3:30. That time just passes really quickly, and then in the end you will have exactly the same things. You have to do your progress notes, you have to administer medications at 12 o'clock or at 2 o'clock, depending on a patient, and then you have to do your handover, you have to fill in the care plans and stuff like that. So yeah, so this about the shifts. Now regarding other cares in this unit, if you watched my previous video on my first sort of reflection or impression about being in this ward for a week, I made my first video. You probably noticed what I said, that I was a little bit disappointed to be sent into this unit because I wanted to practice more clinicals. And Interim Care Unit, it's sort of like a unit as a transitional point for elderly patients who are awaiting their accommodation to be finalized to be moved to aged care facilities. So it's not many clinicals you would be doing in this unit, unfortunately, and this is why I was a little bit disappointed by it, because I wanted to practice more clinical skills, and just gain a habit of doing them, and yeah, just knowing it better. So that was the first week. Then when the second week started and then the third one came in, like, I can say that this unit is not as quiet as I thought it would be. We had more admissions. I had 2 cases with chest pain. I had IDC insertion and removal. Okay, and I've had more meds to administer. Okay, again, more new meds for me, because when you have new admissions, new patients come in, obviously they all come with different health conditions, you know, and they will come with different medications, so there are more opportunities for me to learn more new medications. So that was really interesting, you know. And also when you have more patients coming, there is a lot growing as well on you as a nurse, because you will need to do more cares, you know, so you will have more tasks to complete by the end of the shift and stuff like that. So generally in this unit, I think they have about 42 or 44 beds all in total. Of course, due to COVID, not all of the beds are taken, you know, so generally we had on daily basis about 10 to 11 patients to look after, divided by 2 nurses. That could be RN nurse and EN nurse, and then you would have your AAN nurses, and you will have also your wardies to help you with more difficult patients who are staying in bed most of the time to do their cares. Okay, but last week, which was the 3rd week, we had the highest amount. That was on Friday, actually last day of my placement. We had 14 patients to look after, and I had only 1 nurse with me, which she was RN, and 19 people called sick on that day. And to be honest, like, towards the end of my last week, I was expecting it, you know, and waiting it to finish faster. You know, I wanted to go back to my work, you know, like paid proper work, and I was so tired waking up at 5 o'clock in the morning. So I thought, like, oh, okay, like my last days are going to be nice and easy and crazy, you know. I got comfortable already with the routine and sort of like the whole, you know, life of this unit. I know what to do, you know. I was feeling comfortable, and, you know, like I could perform the cares, you know. I knew my patients and stuff. That, okay, it's going to be like, it's going to be easy and good. No, how wrong I was. Like the last days we had so many new admissions that my last special day on Friday, we had 14 people to look after, 19 people of employers called sick. I had only 1 RN with me, and we had 2 IANs. One of those 2 IANs was running between 2 parts of the whole unit, and it was so hectic and I was so tired. But thanks God that shift is over. We've done all our cares that were needed. Like, we performed really well, and we've been praised by the management that we've done really good job on that day, even though we've been short-staffed. But yeah, like, instead of being cruisy and nice, my shifts at the end were really full on and really busy. So yeah, so you will be looking in this unit approximately starting from 10 to about 12. In extreme cases, you might have 14 patients to look after, divided by 2 nurses. Okay, so that was the experience for me. Now, regarding those cases for chest pain, so that was very educational and beneficial experience for me, again, to watch it, because when you study Diploma of General Nursing, or when you study Bachelor of Nursing Science to become RN, you will come across chest pain scenarios very often, because this is something that happens often in real life with patients, and it's something that has to be treated and reacted really quickly and really seriously. Okay, so it happened to be that 2 patients that I had chest pain episodes with, they were my centered care patients, or the focus patients, which means you as a nursing student throughout your placement will be advised by your facilitator each day to take focused patients. Those patients you will be looking after by yourself and with supervision of the nurse. So for example, you will fill in the planner for those patients when you have your OBS for that patient, when you have your medication administration times, you know, if there is a wound management is due, or dressing, I mean change of dressing at that day, you will put that in. If the water law is due, you know, or a weight or anything like that, you will basically put for yourself tasks that need to be done for that patient, and then with the assistance of your RN body nurse, you can accomplish those tasks by the end of your shift. Usually you will be advised to take about 2 to 3 patients depending on how you feel comfortable, like towards the end of your placement, you can take up to 3 patients, you know, and look after them, you know, but it's up to you really. Nobody going to, you know, pressure you. You can even go with 1 patient and that's fine, you know, as long as you can, you know, look at the history of health conditions of that patient. Just try to link, you know, the medication that that patient is prescribed for, how it is linked to the condition that he or she has, you know, in terms of treatment, you know, and stuff like that. So that will give you a bit more of indication. And this is how we students learn to link, you know, medication to the treatment of certain conditions and stuff like that. So anyways, so those 2 patients, they were my focused patient, and these 2 situations happened in 2 different days. And with the first patient, so this patient has a history of asthma, and that patient came back from the hospital recently with pneumonia. So that person was sent to the hospital to be treated for pneumonia, and then she came back and she still had pneumonia. So that means fluid in her lungs. Okay, and that day I went in, you know, and I just was checking, you know, just all my patients to see how they're doing, if they need any help, you know, and stuff like that. And when I went in, the person said to me that they had chest pain. So I was like, okay, to me, chest pain indication of something serious, something that has to be taken action really that moment, you know. So I asked her really quickly, how bad is your pain, rating from 0 to 10? And the person said to me, it's 6 out of 10. So right away I ran to my nurse, you know, to my RN buddy, and I told her that my patient has a chest pain, you know, and that's the pain score. So the nurse reported to the doctor, and because this was happening in the morning shift, we usually have all the doctors in the unit up until 4 or 5 p.m. Okay, so the doctor came to the room really quickly. She said to us, please do set of obs on this patient, you know. We've done it, and when the doctor saw the set of obs, it was obvious that the patient had elevated heart rate. I think it was going up to 145 or 135, something like that. It was really fast, and she had high respiration rates as well, and high systolic blood pressure. Okay, her oxygen level was a little bit low, but not too low, and the temperature was in the normal ranges. So when the doctor saw the results of the obs, okay, she ordered for us to do ECG on our patient, you know, and knowing her history of asthma and pneumonia, she ordered a stat dose of salbutamol, 6 puffs, and metoprolol. So salbutamol, it can raise the heart rate even higher. So if your patient has a elevated heart rate and you would give this medication, this will bring it even more higher. So if you give metoprolol, on the other hand, together with it, metoprolol can lower your heart rate and it can lower your systolic blood pressure. So that those 2 medications, they will work sort of like in balance, you know, fixing the obs for the patient. So she was given those 2 medications as stat dose, and also after that the stat dose was given for normal saline as nebulizer of 5 mils. So normal saline, on the other hand, can help to clean up that mucus in the airways, and salbutamol can open up the airways so the person can breathe more freely. So that was an interesting for me experience to watch. Also, we've given the patient Panadol to help with that chest pain, because her chest pain was also related to musculoskeletal sort of situation, because when you try to gasp more air, you know, for your body that it needs, and your airways are blocked with the mucus, you work so hard, and your heart works so hard as well, you know, to get more air. And when that happens, you start to experience a little bit of pain in your chest muscles, okay, and you will start to feel fatigued as well, because you don't get enough of oxygen, you know. So yeah, so that was interesting for me to watch. And also for me as a student, when we study something in theory in class and then you see it sort of like in real life, it makes more sense to you, and also you can ask questions and you can see how medication makes positive change, you know, on the patient's symptoms. Like you can see it with your own eyes, which is really, really fascinating. And you can see how quickly the health professionals need to be acting when they have situations with the chest pain, you know, and related to the health conditions that the patient has, you know, the medication that they have and currently taking and stuff like that. So yeah, so that was really good experience for me. Then the patient went also on a medication called I wrote it down somewhere. This medication I came across first time. I haven't seen it before. So a medication called bromhexine, if I'm pronouncing that right. I will write it down on a screen. So this medication can help to decrease mucus viscosity. So this medication was put for this patient as a regular medication, so as she already had it as salbutamol and metoprolol as well, regulars as well. Okay, so they all work together to help that mucus viscosity to be decreased. Okay, so yeah, so this was my first experience with chest pain related to sort of like musculoskeletal situation. My next example and situation was with chest pain related to cardiac sort of thing. So what happened is, this time I was not the one who found the patient. It was my RN who went to the room, and I just followed her because she's my body nurse. And when we went to the room, the patient started to complain of chest pain. So we asked, you know, on a scale of 10, what was the pain rate, you know. So the patient told us, and right away we reported to the doctor. And while the doctor is coming, we grabbed already this machine for obs, you know, and we started to measure the obs for the patient. Okay, so by the time the doctor already was in, and this is just happening like in minutes, it's not like it's taken forever. All these steps are really quick, because when someone has a chest pain, you really have to act quick. Okay, so the obs were that respirations were elevated, so is the heart rate, but the blood pressure systolic was low. Okay, so the doctor came, she saw the obs, and she ordered us to do ECG as well. ECG showed abnormal rhythm, and it was AF, which is atrial fibrillation. This means when you have irregular heartbeat. So if you imagine your heart is having top chambers and bottom chambers, and you know how your blood flows through the chambers, well, when you have irregular heartbeat, sometimes your heart will become like a jelly and start to shake. So the blood is not flowing properly. It just like shakes like a jelly, you know, like vibrates. So so when the doctor saw the ECG, you know, she told us, okay, we are not going to give him GTN because his blood pressure was low, and they've called the ambulance to come and take this patient to the ER or ED, to the nearest hospital to be treated there. In this facility, what I've been explained, they don't have med calls, okay, but they can provide active treatment. Okay, so when something like this come along, situation like this, you know, you can provide active treatment to help the patient, you know, like with the basics sort of needs at that particular moment. But for more serious diagnosis and testing and help, we have to send them to a nearest hospital, to ED department, and then they can do all of that there and put the person into appropriate ward for the further cares. So this is what happened with this patient. So when the paramedics came, they done another set of obs on the patient right in the room, you know, and they've done ECG, and it was exactly the same results as we've got, you know, and the patient was taken to the hospital. So as you can see, these two situations, they had chest pain, but they had sort of like different causes. One was related more to asthma and musculoskeletal, you know, pain. This one was pain more related to cardiac, you know, whatever causes and underlying conditions the person had, you know, in the second situation, you know. And also when you have, you know, decreased blood, you know, going through your heart, you know, and oxygen as well, you will experience chest pain as well, and you will be fatigued. And I could obviously see that my second patient was fatigued. I could clearly see that the person was tired looking, you know, and trying to breathe so much, you know, to get more air going in the body as well, and for the heart to work more harder. So yeah, so again, it was really interesting for me to see. Again, I am a student at this point. My knowledge is very limited. I can only judge to the knowledge that I have at the moment and to information that can be explained to me by the nurses, you know, and observe just the situations. I wish and I hope for more knowledge to come throughout my next placements, you know, and I want to research more on internet when it comes to chest pain, you know, and treatment options, you know, and also why people have chest pain, because there are so many different underlying causes for just chest pain, you know, and so as the treatment options, you know. So this is very, very interesting topic for me, and hopefully before my uni starts on 20th of July, now since I'm free from uni and from placements, I want to try to do more research on all of these topics and just educate myself to know more about it, because this is very, very interesting. So yeah, so those were sort of like the biggest highlights of my placement, I guess, because it's related also to the scenarios that we've done in class during my studies. Also, I had a practice of removal and insertion of IDC, and again practicing bladder scanners. So in my previous placements in surgical wards, I've done a lot of blood scanners, because when you have someone coming from the surgery and you need to remove the IDC, you need to do a trial of void, and after the trial of void you need to see if there is any retention in the bladder by doing a bladder scanner. So in this facility they had a little bit different machine for the bladder scanner, which was a good practice for me to try to use different equipment, and yeah, so that was fascinating. And what else have we done? I think that was the most like clinical sort of situation that happened to me. Rather than that, I've learned a lot of new medications, upon new admissions, because as I said, every person comes with different conditions, which means you will have more medications to learn. And I wrote a lot of medications actually on a piece of paper, like I have it here and on the other side, and I have a few of these papers, and I have to put it in my small pocket book where I have all my medications in it. And to be honest, it's almost full. I don't know at this stage if I will be starting a new one, but we will see. I have still like few spaces here and there left, but yeah, like it's really helpful, because every time you write a new medication, it makes you to remember it even more. Okay, so that was it in terms of cares. So if you ever looking at working in this unit is sort of like reminding me more of aged care facility. Plus a little bit of clinicals may happen there, but it's otherwise it's very, very similar to aged care facility. You as a nurse, you will be still doing, your medications, then you will do your progress notes, and you will do your handovers to the next staff, you will do ADLs, cares and assistance and stuff like that, wounds dressing change and things like that. So it's very, very similar to aged care. Okay, so if you're looking for something like that, that could be an opportunity for you to choose between aged care or something like that. Okay, next, I had a lot of questions actually asking me, during your placement as RN, what type of documentation you need to do as a student, okay? Is it very similar to TIFE, Diploma of Enrolled Nursing? Okay, I can tell you that when you go on a placement, you don't have logbooks, as I had during TIFE studies, okay? We don't have logbooks, but we were given a book like that, which is called Student Placement Learning Package, and this book is pretty much a book for yourself. In the beginning, you will have information about the unit and facility that you go into, and then in the end, you will have some forms that you will see in a patient file or in a patient folder. This is the blue folder that you usually have it on the side of the patient bed. Okay, so you will have few forms here, like for example patient care record, your OBS, your rounding log, some of the abbreviations, your pressure injury assessment form, your elimination management chart for bowels and stuff like this. This is if you imagine if you went to uni, never been to TIFE, so your first year of studies at uni, you will only have your placement at aged care facility, okay? And you will be limited there because it's aged care facility. So you might not come across different forms that they use in hospitals when they look for patients, So when you have this book and you not knowing any forms yet, this book can actually give you some, insights and some sort of like education on type of forms that they use in that particular unit and what's written inside those forms, so you can know what the form is about. So yeah, so that was the book. This book is not returnable to your facilitator or to university. This is just for you for general knowledge. They have some activities in here that you can fill in, just for yourself, and have some fun, and it stays with you. So next, your facilitator will tell you that you will need to choose 2 goals per week, okay, and complete those 2 goals by the end of the week. This could be any goal you you want to choose for yourself, but you will be given an indication to help you if you want. So my facilitator, she gave us tasks that we may do in our semester 1 and semester 2, but semester 2 was not applicable for this placement yet. So for semester 1, for example, medication calculations, schedule 4 and schedule 8 medications, subcuts, IM injections, IV medication, burette pumps and boluses, reconstitution of medications, administration of blood products, pain management, and PCA management. Obviously, most of it we didn't have in this unit, although we did have medication calculations which were really easy in terms of oral medications. You just needed to calculate the doses. If for example, coming up pack of the medication is different to the dose that's been ordered by the doctor, you need to see whether you need to give half of the tablet or quarter of the tablet or 2 or 3 tablets and stuff like this, depending on a strain. And we did not have any IVs, okay? So I could not choose much of this to put as my goals, because this is something that we practiced in our labs and I couldn't practice it here on my placement. So what I've done for myself, my first 2 goals for the first week were practicing more administration of medication and being safe and knowing my medication and its side effects when I'm administering it. And second one, I chose for myself time management. I wanted to make sure that I can time myself and follow my planner throughout my shift to make sure that by the end of the shift I completed all the goals and all the cares that needed to be done for my focused patients, and also to help the other girls, my nurses, to look after the patients as well. Okay, so those were 2 of my goals for the first week. And then your facilitator will ask you to write a reflection. Okay, reflection could be on completion of your goals. Reflection could be your general way of how you felt throughout the first week, and whether you were happy with the support that you were provided by your nurses, by the RNs. Did you succeed with, for example, certain cares? Did you learn something new, or did you have difficulties and stuff like this? If there's areas to work on still, you can put it in your reflection as well. Like, for example, you can say that I was safe during administration of medication, but I realized that I need to learn more about specific medications, knowing its indication, its side effects, and how these medications related to the conditions that it's treating in my patient and stuff like that. So this is really easy. You have to do it only once a week, and that's it. And you will give it to your facilitator. She will probably scan it and send it to the uni, and then she will give you back what's you written on a paper. Then she will tell you, but again, this depends on a facilitator. Just my facilitator told us that we have something called nurse supervisor feedback form, okay, that looks a little bit like that, but again, from unit to unit can look different. So when you have your shift over or towards the end of your shift, you can speak to your RN buddy and see if she can fill in this for you. So she basically needs to tick your competencies, and she has to put areas that you've been good at and areas that you need to be improved at, and that's it. So my facilitator asked us to only give her 3 forms per week, not 5. So for example, if I'm attending my placement from Monday to Friday, she didn't need all 5 days. She said 3 forms is enough for me per week, okay? So literally you can pick any 3 days out of your week, give to your buddy nurses, fill it in, and give it back to your facilitator. So she will keep those forms. She's not going to give it to you back. Your facilitator, that will stay with her, and I think they will go back to the uni as well. I would advise you though, speak to your nurse, not in the end of the shift, but maybe an hour or 2 towards the end of the shift, because when the shift is finishing, you still have 2 o'clock medications, you still have to do the progress notes, and then you will have your handover starting, so it's not much of a time left in the end. So find that sweet spot somewhere, maybe 2 hours towards the end, and this is when they can actually pay some time to fill in your form. It will take them maybe 5 to 10 minutes. It's not really hard. So yeah, then what we've been given as well is a attendance sheet form, okay? So it's very simple. It stays with you. All what you write in here, hours or running total, time that you spend on your shift, day, time when it's ended and started, and then your facilitator will sign it for you. At TIFE, I remember that my attendance were signed by my body RN. So whenever I finish my shift, I have to go to my body RN, you know, and she would sign that I've been on that shift, you know, and I've been practicing with her. Here, as RN student, you don't have to do that. You just give this form in the end of the day when you're meeting with your facilitator, and she signs it for you and it stays with you. I think she does copy it for herself, but you will have your original with you. And the last thing that we've done, that was sort of like an activity that just happened once throughout whole 3 weeks. Okay, our facilitator gave us something called National Safety and Quality Health Service Standards, and she said to all of us, because we had, I think we were like 7 or 8 of us from different units, and she said, okay, any of you can pick one of the standards and make a small presentation of maybe 300 words. Okay, so I picked medication safety because this was related to my first 2 goals at that time. And when we had the debrief all together, we have presented, each one of us, the point that we prepared. Okay, no references needed for it at all. We just could have researched it online, you know, by ourselves and related to the practice that we've been doing throughout our placement and stuff like that. And this was just sort of like educational sort of like part for all of us and reminder. And that was it. That was so simple. As you can see, you don't have anything like in logbooks in a type when you needed to provide situations for each nursing standard, you know, and related to your situations and experience happening throughout your placement. We didn't have any tasks that need to be signed off when we do it, you know. The only common thing would be reflection. Here and there you need to do reflections, you know. And also at university we have something called Sonia. This is online database for all the placements. You have your personalized username and password to enter, and when you enter you can see all the information that you need for your placements. So there in forms section we needed to fill in another sort of like reflection sheet, and that was a summative midway and endway. Okay, this is where you put just ticks, you know, for your performance on certain tasks, and then in the end you write your reflection, very similar to what you've done on a placement itself with your facilitator. But this one document, it goes to the uni, so you have to do it midway and the end. The end would be exactly the same form, but you have to fill it again, already adding more experience, you know, and more things to talk about in your evaluation. So if you were not comfortable about some sort of cares in your midway of placement, maybe you've gained more confidence, you know, more practice, more habits and stuff like that, and you can be already more confident in providing those cares in the end of your placement. And this is what you have to talk basically in your reflection in the end. So yeah, that was it. Not much, as you can see, not much of paperwork at all. As a student, your facilitator may come to you during your placement and ask you to administer medications together with her instead of RN body. She just wants to see if you are safe when you administer medication, because administration of medication, I repeated so many times before, it's very important in your nursing practice, because if you give someone wrong medication or wrong dose, you know, or didn't pay attention to the allergies that the person have, and only relying on the way that the order been written by the doctor, you know, you may make an error, because sometimes physicians, they can have errors too, you know. So you as a nurse, you're like a backup there, you're checking after them, you know. So yeah, so your facilitator can check you. For me it happened only once. My facilitator came once, it was midway, and she went through with me and with another student, and we've done a morning administration of medication. We've done on one patient. She just checked me on one patient, and that's it. So yeah, so that was it. Sometimes she would come and see if you are giving handovers, if you're confident and feeling comfortable with that. Yeah, so this is it in terms of documentation as a student and the facilitator. It's okay, it's not really scary things, it's very easy. Okay, next I want to talk really quickly regarding the documentation that you will face as a student towards the cares and the medical folder of the patient. Okay, so in this facility I came through a document in the patient's folder called rounding log. I've never ever seen it before. Okay, so basically this form, you as RN or RN student with supervision of your RN buddy will need to sign on each shift, and it goes by hours. So pretty much this form is that it has letters in it, and each letter represents a certain meaning. Like for example, did you offer or check if your patient has any pain, you know, or they need a pain relief? Did you recheck repositioning for the patient if the patient is on a pressure care, you know, schedule for turning and repositioning and stuff like that, you know? Did you ask if the patient need any assistance with feeding or finding a remote control for the TV, or maybe calling the relatives and stuff like that, you know? Or maybe the person just wants to have a walk or read a book or something like that, or have any other concerns. So you have to assess your patient every hour, just see if they need anything, you know, and stuff like that, and sign off. So this was something really new to me, and I've never seen this form before, but I can see now from my experience that this form is actually very important, and just keep you up to date to not to forget to actually look and ask if your patient has any concerns, you know, and just make sure that you feeling their needs and they are well looked after. Okay, then you will have in the folder of the patient, I'm talking now about the blue folder that you have on a bedside, you will have medication chart in there, you will have risk assessment for pressure injury, for falls, you will have wound management document, which is really good one. It's a form where you can see if the patient has a dressing, if they have a wound, you know what type of wound it is, how often the dressing need to be changed, type of the dressing, what is the cleaning solution can be used, and so on and so forth. So this will give you indication, you know, if that particular patient will have on your shift a dressing change. Sometimes you will see some nurses would put a date on a dressing, but not all of them do. Okay, then you will have your BGL or insulin form. Okay, this one would be usually in front of your medical chart. Okay, and this form will indicate for you whether the person who has diabetes on a standard BGL check or on BD. BD means twice a day, usually performed in the morning before breakfast and at night. Okay, if it's a standard check, that would be pre-meals and at night. Also, some of the people who have diabetes may be on an insulin sliding scale. Okay, this is something for you to learn, because this is important as well if you want to practice your subcut insulin injections. Okay, so your nurse can explain to you how it works, but basically it's very easy. When you check your BGL level, okay, on a sliding scale, you will have sort of like levels into certain brackets. So let's say if you have BGL from 0 to 8, the person may be on 0 units of insulin. If you have from 8 to 12 in these brackets, okay, you will be having maybe 2 units of insulin. If you go from 12 to 14, you know, if you're in these brackets, your BGL, you will have 4 units. And then you will have your regular fast-acting insulin and maybe slow-acting. If the person is on fast and slow-acting, that could be your fast-acting Novorapid, and for example, Lantus is your slow-acting. So you will have your regular insulin form as well, and it will tell you that in the breakfast time, you know, pre-meal, you will administer regular dose of 10 units, let's say. Lunch, maybe 12 units. Dinner, maybe again 12 units, or maybe less, you know. So when you do your BGL, you see what is the number, what is the level of the blood sugar, you know. If it's, let's say, 12.5, and you are now in the morning time, let's say, so you look, okay, so this person in the morning has Novorapid 10 units pre-meal. So my BGL today for this patient is 12.5. I look down on my sliding scale at this, and I see that in the brackets from 12 to, let's say, 14, the brackets might be different. I'm just giving you an example. I don't remember them by heart, but let's say in the brackets from 12 to 14, if your BGL falls into these brackets, you will administer 2 units of insulin. Okay, so if my BGL of my patient was 12.5, he falls into these brackets. So it means I have regular dose for morning 10 units plus these 2 units makes it 12 units for me to administer as subcut to my patient. When you do insulin, you as a student cannot be a second person to check. You will need to have 2 RNs to check, okay? So you will be the third person as a student. So once you withdraw the insulin to the syringe, you know, they can allow you to administer it as a subcut to your patient. And you can practice this with every meal, so you could know and be comfortable how to give subcuts, okay? So that would be a great opportunity for you. Always remember to check if the patient is on a standard BGL checks, you know, if they have regular doses of insulin and stuff like that, so you won't forget. Usually insulin is given just before food, and BGL can be checked maybe half an hour before food and stuff like that, okay? So that would be it. What other charts you will have? So you will have elimination chart, which is for the bowels. This has to be filled in every day. And then you will have a form called, I'll try to find the name for it now for you. It's called Patient Care Record. Okay, this is very helpful form, and I think I do have it in this book as well. Here we go. It looks like that, okay? Patient care records, and you will have a lot of sections here giving you information about patient. Usually in real life it's two-sided, okay? So the most important section for me as a student was medication, which is on the other side, okay? Here in medication it says swallows whole or needs crushing, okay? I'll tell you quickly how I use it. For example, because this unit has a lot of elderly people, obviously a lot of them have problems of swallowing, especially when you have big pills, okay? So you will find even for fluids and food, some of them will be moist and soft, some of them will be on, you know, blended food, some of them will be on thickened fluids and stuff like that, you know. So with medication, it's the same, you know, they will have problems swallowing it. So how can you know if the patient needs to have their medication crushed or they can actually swallow it? You can ask them directly, but if they have dementia, you can't rely on the answer, you know, and you don't want to choke anybody as well at the same time, because you have to provide safe cares. So when you go to this form into medication part, you can see whether the swallow holes was ticked or the needs crushing was ticked, and that will give you indication whether you have to crush the medication for that particular patient or not. Then you may have a question, okay, how can I know which medication can be crushed and which not? Because let's say if you took a medication that is slow release and you crushed it and you gave it to the patient, that medication can potentially become a fast release, you know, because they have specific coats in there, they have specific layers, you know, to make it slow release. So what I've been explaining, the easiest way, when the doctors write, you know, medication order, at the bottom of each medication section, if that medication can't be crushed, it will be written in a purple color by the pharmacist or by the doctor. It's written swallow whole. So if you see any medication that has that written on it in the med chart, it means that particular medication cannot be crushed, but all the other medications can be crushed, okay? So you look only for that particular writing. This is how it wasn't explained for this unit. I do know, though, there is a book, I think it's called Crushable or Non-Crushable Medication, something like that, and we used to have it at TIFE. I haven't seen it at uni in our labs, but I will ask this semester if we do have it. But at TIFE we used to have that book, and that would give you indication as well whether the medication can be crushed or not, okay? But in this particular unit, this was the way we went to, and this was really easy, okay? So that was really handy for me. Then this patient care record will give you indication how often person has to be having their OBS, whether it's TDS or QID 3 times a day or 4 times a day, whether it's on standard or BD, BGLs, but also always check your BGL chart as well, just to make sure your wound care, you know, cognition, behaviors, mobility and stuff like this. So patient care record is very, very similar to care plans that they have in other hospitals. This is what I'm judging now from my own experience, okay? It's just the layout of the forms is a little bit different, but the information provided in it is very, very similar, okay? So I think that would be most of the medication that most of the forms that you would come through. You know, you might have a weight monitoring chart as well, or fluid balance chart, where you have to record output or an input, especially for people who have their IDC taken out. You have to monitor output and input, you know, to see the differences there. And yeah, one more document that you will have is going to be sort of like in a admission pack, and it's called 4AT assessment test for delirium and cognitive impairment. Okay, that form you will need to fill in for the people who've been just administered or admissioned to the care unit, and that form will stay in blue file or blue folder of the patient. Okay, all the other documents that you will have on admission, they will be a little bit more than what usually stays in a blue folder, will go to other folders, which is your personal file of the patient, which is a yellow folder that stays in the medical room. Okay, and that's sort of like a history of all the other admission forms that the person went through in different facilities, in different hospitals, you know, test results, you know, previous medications and stuff like that. So it's like a health record, you know, folder and stuff like that. So yeah, admissions on the other hand, they're really interesting to watch and take part in. I had quite few admissions that I took part in. The other ones I was just watching, you know. And for me, admission, it's like solving a puzzle, because sometimes when your patient come from different hospital, you know, you have to fill in all these forms that are in place at your facility, you know. So you have to find, you know, previous medical history, you have to find, you know, medication, you have to find QADs on OBS that previously been taken, you have to find whether this patient, you know, is diabetic, you know, has any pressure areas, you have to do skin assessment, you know, you have to assess all the dressings and stuff, like behaviors, you know, and habits and all of these things. It's so interesting. You have to go through the whole health record, this yellow folder, you know, patient file, and see all these documents from previous facilities, especially recent ones. You wouldn't relate it really like really back ago. You just need to relate to the previous ones, you know, the latest ones, and fill in your paper. And then you have to assess your patient as well, because you can't rely just on the previous records only. You have to assess by yourself as well. So for me, it's really interesting, because it's really like solving a puzzle. You have to search for all this information, and it's really fun, and it just gives you more information about the patient. Because once your shift is finished and you administered or admissioned a patient, you have to give a handover about this patient to the following shift. So doing all the paperwork will give you a full idea about, you know, condition of this patient, you know, what medication they are on, what their physical, you know, condition at the moment, stuff like this. And then you can give all this information to the coming shift as well. So yeah, so that was interesting. We went through some discharge, and at this unit, discharge summary is done by the doctors. Okay, and then you as a nurse, you just attach it to the all the files of the patient. So basically, when the patient is discharged, let's say to the hospital, like with the chest pain condition, what we've done, we took all the forms in the blue folder for the patient, and we put it in an envelope, and we put the discharge summary on it, and we sent it to the hospital, so they could see what was the BGLs, what medication the person was on, the care plan and stuff like that. So again, for you as a student, very important, when you provide any cares, you know, or you do OBS, or if you sign something, make sure that everything is correct. Make sure that you are co-signed by your body nurse, because if anything, any emergency happen, and your patient will be taken with all their medication to a different hospital, and God forbids, but anything else can happen there to that patient, they will relate to all these documents. So just stay always on a safe side. Make sure that any OBS you do, any case, as I said, always co-signed and witnessed or showing, you know, to your nurse. You know, don't just act by yourself and leave something unsigned. You know, just protect yourself, protect your patients, protect the other employers who are working with you. I think this is all what I wanted to say about this placement. Now I will be back to uni on 20th of July, so I have a little bit of time for myself to recap, you know, and just go through some information that I want to research just for my own knowledge. You know, I want to research more about medication that I came across during this unit, you know, and yeah. I always do this after each placement. I just like to research more information about for myself, you know, and learn more. And also I will try to record more videos as well, because now I only have my work, no uni, no placement. So I'll try to do more nursing videos. And a few people were actually asking me if I can record a video from my previous placements in medical and surgical ward. So I will do that, so you guys could have a little bit of insights of what's going on in different type of wards, you know, what students they do. But I will record it as a perspective of EN student, because this is when I used to do my diploma of enrolled nursing, so I can do that for you guys. And yeah, so I will try to be more consistent in the next months with my videos, and I'll see you in my next one. If you have any questions, please leave them in the comment section below. I will answer them all according to my knowledge and my experience, although I'm still learning this, and if I don't know something, I'll tell you honestly I don't know. But if I do have a knowledge, I'll answer it according to my experience. And yeah, thank you already for all your likes and your comments on all my videos. I can see that my videos somehow become useful for you, and I'm glad that I can help you guys with some information. I'll see you in my next videos. Bye!